section. All right, what's going on, everybody? Good to see everyone again. Everyone gathered to crush knowledge. All right, so I wanted to start off tonight with thank you all for doing the knowledge checks on some of the shock stuff we talked about, just to rehash and reinforce some of the things we talked about. Most everybody did pretty well. The couple questions was differentiating sort of physical exam findings in cardiogenic shock versus distributive or septic shock. So, and one of the questions was, what is the pulse pressure like? And when I say pulse pressure, I'm talking about the arterial line. So if you think of cardiogenic shock, the heart's not functioning that well and the cardiac output's poor. So the systemic vascular resistance, or the body's catecholamines, are going crazy to vasoconstrict to try to maintain pressure, right? They're trying to squeeze those pipes. So what I meant by that was you're going to see a narrow pulse pressure. So this is systole on the A line, and this is diastole. And you can think of that as like what's coming back to the heart in the constriction. So you're going to see like a narrow pulse pressure. So something like 85 over 70 or something, 85 over 65. Now, contrast that, and you're going to have a thready, weak pulse peripherally. Distributive shock, cardiac output generally isn't the problem. The heart's pounding away. It's just that you have the sepsis and the vasoplegia, and paralysis of the vasculature essentially keeps it wide open. So you don't have that vasoconstriction capability. So you don't have that diastolic sort of squeeze back to the heart, increasing your pressure. So you see systole, heart pumps out, and then it's kind of wide open, and diastole, you get a low pulse pressure. So that's where you see like our people that come in with sepsis, they've got maybe a blood pressure of like 100 over 40 or something, or 100 over in the 30s. It's because they don't have any tone in their vasculature because they've got septic or distributive shock. Does that make sense? So you're going to see more bounding pulses and less tone in the vasculature. That's going to be seen in the A line as a wide pulse pressure, again, like 100 over 40, 35 or something. Versus cardiogenic, you're really trying to squeeze the vasculature, and so you're going to have a narrow pulse pressure. Everybody kind of understand that? Okay. But pretty much most everybody got that right. So just to recap. Okay, so tonight we are going to talk about vasopressors. All right, so where to even begin here? Okay, so I think we should begin with terminology. Does everybody know what vasoconstriction means? Okay, so increased tone of either the venous system or the arterial system and constricting. Inotropy, does anybody know what that means? Inotropy means basically heart contractility, okay? So contraction, and how vigorous is the heart contracting. And then vasodilation is kind of what we were just talking about. Sepsis, arteries, veins, everything's wide open. There isn't much tone, okay? So we have vasopressors that fit all over the spectrum of vasoconstriction primarily pump function, increasing contractility, and then just as a comparator, we have some heart medications that do purely vasodilation. That's not treating shock so much as it's treating like severe hypertension, and that's just as an example. So we're going to fill in this chart, and where do the different vasopressors and inotropes fall on this chart, and what happens when you increase the doses, where do they lie? I think next what we'll talk about is just where are these vasopressors working, okay? So this is the heart, this is the aorta and the arteries, this is the veins here. And this is like the inferior vena cava and the venous system that comes back to the heart. So blood comes back to the heart, goes from the right side, goes to the lungs, get oxygenated, goes to the left side, and then the left side pumps it systemically. So in our arteries and our veins, we have alpha-1 receptors V1 and V2 receptors, alpha 1, V1, V2 on both the arteries and the veins. Can anyone tell me what alpha 1 does when we stimulate it? Vasoconstricts. Okay. Anybody have a example of a alpha 1 agonist? A purely alpha 1 agonist? What? Yeah, phenylephrine. Perfect. So phenylephrine, we're going to fill in here. Purely vasoconstrictor. Phenylephrine. Okay. So that's a pure vasoconstrictor. V1 and V2, does anybody know what we give often in the ICU that hits those receptors, causing vasoconstriction and venoconstriction? Alpha and V1 and V2 do it on both the arterial and venous side. Vasopressin, perfect. So vasopressin is also going to be right here. It's going to vasoconstrict. Okay. Anybody else know something else that it's just alpha? Sometimes like we get a cirrhotic patient or a sepsis patient, we've like almost taken off pressors. So we like get annoyed with their maps being like 60 and we want them to go to the floor, so we just like put a little midodrine down the patch. Yeah, there you go. So midodrine is kind of like a weaker alpha agonist, but it's kind of like our only like oral vasopressor. So midodrine's in that boat. What's our like big gun that we use like all the time, first line typically? Levofed, norepinephrine, okay? So norepinephrine, so we've gone from pure vasoconstriction to norepinephrine sits more here. We'll say high dose norepinephrine. So not only does it alpha vasoconstrict, but it also has some beta characteristics. And does everybody know what beta does? Where are we now? If we're not just vasoconstriction and we're moving towards what? Inotropy? So contractility. So it's going to hit you with increased contractility of the heart, and then also peripheral arterial constriction and venoconstriction, okay? Because it's going to hit your alpha 1, but it's also going to hit your beta 1. And it's also, in here, you could also put /chronotropy. Chronotropy is how fast is the heart going. So it's going to increase your rate too. So norepinephrine is going to do that. And so it shouldn't be a mystery to anyone why that's kind of like the first one we pull for, right? It's sort of like the jack of all trades. It does everything. Okay. Moving on. Now does anybody know where epinephrine fits on this little algorithm? Because there's a low dose epinephrine and a high dose epinephrine. Do you know what low dose epinephrine gets you?
To the right? Or inotropy, chronotropy?
Yeah, more beta. So low dose epi and dopamine are here. Okay. And then high dose dopamine. We don't really use dopamine. This is just for being inclusive of all of our pressors. I don't want anyone to feel left out, even though, unless you're like, I don't know, in the middle of the desert and that's like the only thing you have, then sure, try dopamine. And then high dose epi is here. Okay.
What's
what's low dose epi?
Yeah.
Yeah. So I don't 100% quote me on this, but I'm pretty positive like low dose epi is considered like 0.01 to 0.1 micrograms per kilogram per hour, somewhere along that range.
Yeah.
And like high dose norepi is more like 0.3 micrograms per kilogram per hour. I think if you're going to do just milligrams per hour, it's like 15, 10 to 15. It's like over that is when you're getting like high dose. So now, when we're in high dose, so low dose epi, we're more beta, and then we get higher dose epi, we're acting a little bit more like norepinephrine, okay? And we're up in the vasoconstriction, venoconstriction, as well as inotropy contractility, as well as these two also do chronotropy, so they're going to make you go faster, especially epi. That's why I typically stay away from that in people who are already like tachycardic. Okay, but it's good for someone who sometimes older people don't mount a heart rate response, so you can try to give them epi and they might respond to that. All right, now, does anybody know another beta 1 agonist that we use typically only in like cardiogenic shock? What's that? Dobutamine. Yep. Dobutamine. Well, wait a minute. So I put it down here. So it's an inotropy, increases beta activity. It's going to give you a little chronotropy too, going to increase heart rate. But now what box are we falling in? We're also falling in vasodilation. So these are called inodilators, okay? So they're going to increase your contractility, but they're going to dilate your peripheral vasculature a bit. So they can drop your blood pressure a little bit. And then does anybody know the other one that vasodilates you even more?
Milrinone?
Yeah, milrinone. This works through a different system than beta 1. It's called like cyclic AMP, but it basically increases contractility. Also vasodilates more, and this gives you a little bit more pulmonary vasodilation. So this is something we like for right heart failure, exactly, and right heart strain. Okay. Now, to be a pure vasodilator, that's like a nitroprusside. Just to give you a comparator. Phenylephrine polar opposite would be like nitroprusside. And a drip like that. Okay. So, does anybody have questions with regards to where these fall on this spectrum? All right, now, yeah.
Microproside, I've never seen it used all on its own, nor I ever worked with it.
Yeah.
Do you usually use it in conjunction with something else to aid that drop and contraction?
I typically don't use it either. Usually I'm like a cardiac person. Nitroprusside can like really drop you.
Right.
It's a little bit can be a little bit finicky, so I don't typically use that. I would use cardine or nitroglycerin or something like that. Okay. So you're not going to get away without an equation and then like putting this all together. So what's the whole point of this whole thing? What are we trying to do? We're trying to maintain appropriate cardiac output to meet the metabolic demands of the tissues, whether cardiogenic shock, septic shock, whatever. So we're trying to maintain, what does MAP stand for?
Mean arterial pressure.
What does CO stand for? Cardiac output. Systemic vascular resistance, think clamping, okay? Increasing our systemic vascular resistance, okay? So, does anybody know what makes up cardiac output?
Heart rate and stroke volume.
Nice question. Heart rate times stroke volume. And now, bonus question, stroke volume can be broken up into two different things too. I think I heard it. Preload and out. You part of it. 50%. It's not passing.
Yikes.
Tough crowd.
Out. Get out.
You fail.
You fight. Contractility. No, that's very good. Okay, and then systemic vascular resistance. Fun to say. Think constriction. Okay. So, let's break this down a little bit more. So, what things here did I talk about that increase our heart rate?
Which medications?
Yeah.
Neo,
Norapi, epi, dobute, dopamine. Okay. So that will increase your heart rate. What things are going to increase? So when I say preload, think venous return. So what things cause venoconstriction, return to the heart? By default, you deliver more to the heart's going to contract more if it's a normal heart, and increase its cardiac output and MAP. So what things increase preload? Norepi, epi, at high doses. High dose epi. What other things constrict? What other things constrict? Phenyl, ephrin, vasopressin, midodrine. Okay. What makes us contract? Norepi, epi, dobute. What do we say? Norenone, right? And then think of this on the arterial side. It's essentially constriction. Same. Norepi, epi, phenyl, vaso, midodrine. All right. So we have taken the mean arterial pressure, we've broken it down into its component parts, and then we've basically identified all of our vasoactive medications that we give and where they fit into the puzzle. Okay? So it's up to us to figure out where do we have a deficit here and how can we fill it in the hypotensive patient. And so look. Norepi does it all. Okay? So that shouldn't be a huge shock as to why it's probably our first line vasopressor. So does everybody understand how vasopressors work, where they work in this spectrum, and this equation? Does people have questions about that? Does that make sense?
I have two questions.
Crystal clear? Redemption.
The first one. Does methylene blue land on that anywhere?
Oh, yes. Yes.
See, I did redeem
It does
myself.
not. No, that's great. Methylene blue is a nitric oxide scavenger. So is thiamine. So what does nitric oxide do? Vasodilates, okay? So in distributor shock, septic shock, you're basically trying to saturate all these receptors, vasoconstrict, improve all these parameters, but you still have nitric oxide kind of fighting you. That's floating around. So methylene blue basically scavenges nitric oxide and takes it out. So it basically is an augmentee of these. It doesn't vasopress, it scavenges the vasodilator that you have naturally in your system. Does that make sense? Thiamine. Difference is methylene blue is like, I don't know, I think like $60 a dose, and thiamine's like a lot more. Or maybe it's the other way around, I don't know. But I think methylene blue's a little bit cheaper, and the formulation of thiamine is like quite expensive. So we would use like methylene blue in a few.
Do we have
If you really wanted to scavenge some nitric oxide, but that's how it works. If that makes sense.
My second question is, for neurogenic shock, when they vasodilate and they're unable to like send the trigger to constrict, do they respond as well to levo as like a cardiogenic shock would, or is a different
They
medication
will.
for them?
Yeah. We had some spinal cord patients at shock trauma that had definite like neurogenic shock, and they'll respond to phenylephrine, norepinephrine. Yeah, typically. I don't have extensive experience with them in treating neurogenic shock, but I have seen them respond.
Because they Brady down a lot too. Would epi be like a better first?
Well, I don't think so, because again, norepi high dose is going to do it all, So it's because they've basically gotten a sympathectomy. Like their sympathetic system doesn't work as well, and they've got some neural inputs, some not, and basically their sympathetic chain is just hosed, so they can't perform. And sometimes some of it recovers, but a lot of times it's just such a shock to the system that they need a little vasopressor. Cool. So vasoconstriction, venoconstriction, and arterial vasoconstriction, alpha 1, V1, V2, norepinephrine, phenylephrine, vasopressin, midodrine, same, beta 1, norepinephrine, low dose epi, high dose epi, dobutamine. Milrinone works through a different CAMP in the cells, but same effect in terms of inodilating, but increasing contractility. Okay? And then with this equation, we can like tag all the pressors onto the like skeleton of knowledge. Like this is where they fit into the equation, and this is how we make it make sense and increase our map. Because our map is directly related to these variables. And that's how we manipulate them with those vasopressors. 4 minutes early. Oh,
Great.
another question. Wait a minute.
Oh, of course.
Can you speak briefly on to, I bet you heard that question about what do you take off first, vaso or levo?
That's going to be next round's
And what?
talk about how do we start pressors, what are the trials that say this is why this works, this is why this doesn't work, when do we add steroids and all those things. Short answer, you take off norepi first, then vaso. And I'll have some of the data next time about why we do that.
Nice, all this knowledge. Okay.
But yeah, the next talk is going to be more specifically about septic shock, since we see it so much, and then how do we approach our pressors, and then not only how do we approach our pressors, but okay, things aren't going right. We're adding more pressors on. Like what do we need to be looking at and correcting in order for us to either have our pressors work, or are we missing something we have evaluated, and are they not working for a different reason? So that'll be next time. Still on time.
Perfect.